We are going to compare two outcome measures for knee osteoarthritis, the Western Ontario and McMaster University's Osteoarthritis Index, otherwise known as the WOMAC, versus the Knee Injury and Osteoarthritis Outcome Score, otherwise known as the KOOS. My name is Rachel Sadinsky.
And my name is Starla Schwartz.
The Western Ontario and McMaster University's Osteoarthritis Index was created to evaluate the disease process and the patient's response to treatment in someone with knee or hip osteoarthritis. In this presentation, we're just going to focus on knee osteoarthritis. Some background information on the WOMAC is it was developed in 1982 and since then has undergone multiple revisions. The most recent revision was the WOMAC 3.1. It's available in over 80 languages. All of these revisions have added multiple other languages. The WOMAC is broken into three subscales. Those three subscales are pain, stiffness, and functional activities. There are 24 items total on the WOMAC. The WOMAC is available in three different scoring formats: a 5-point Likert scale, a 100 millimeter visual analog scale, and 11-box numeric rating scale. A benefit to the WOMAC is that each subscale is scored individually, which makes interpretation of the results easier. The WOMAC is a valid tool for patients with osteoarthritis and shows good face, content, and construct validity. Face and content validity increased because the test was developed based on input from patients with osteoarthritis and academic rheumatologists and epidemiologists. The WOMAC is responsive to change post-surgical intervention and non-surgical intervention performed in patients with osteoarthritis. The WOMAC was also found to be reliable. A couple problems with the WOMAC is that they found a few things that could be redundant on the WOMAC and that should be deleted. So they found that performing light chores, getting in and out of cars, and rising from bed are redundant, and that heavy domestic duties and getting in and out of the bath and getting on and off the toilet should be removed. So these items were just found to be too easy. The WOMAC is good for clinical use. It's definitely feasible. It can be administered in multiple different ways, either self-administered or interview-administered questionnaire. There are minimal floor effects and only ceiling effects reported for post-total knee replacement. It only takes about 5 to 10 minutes to complete the questionnaire and only about 5 minutes to score the questionnaire. You also don't have to be specially licensed to score the questionnaire. A possible downfall, though, is you do need to be licensed in order to use the test, and in order to become licensed, you have to apply online and pay a fee. The WOMAC is feasible in research as well. It's found to be reliable and valid, and it's also responsive to change.
The Knee Injury and Osteoarthritis Outcome Score is a self-administered questionnaire aimed at assessing long and short-term outcomes following knee injury or osteoarthritis. In this presentation, we are only going to be focusing on the knee osteoarthritis. This is a self-administered measurement tool, and this is done on purpose to avoid observer bias that may be introduced with an assessor giving the tool. The WOMAC is mainly used for elderly patients with knee osteoarthritis, but there were no validated measurement tools for younger patients who may have had OA post-injury or trauma. So that's the reason that the KOOS was developed. It's for younger and more active patients. The KOOS is assessed in 5 different domains. That is pain, symptoms, activities of daily living, sports and recreational activities, and knee-related quality of life. Each individual item is scored on a 0 to 4 Likert scale, and like the WOMAC, the KOOS is scored separately for each domain, which makes interpretation easier. The best score a patient can get is 100, and the worst possible score is a 0. In terms of psychometric properties, this is a valid tool for patients with OA. Content validity is good because the authors have consulted with a panel of experts who were patients who had OA in order to ensure that all aspects of osteoarthritis are addressed. There's no gold standard to compare this to, so it was compared to the short form 36 to obtain convergent and divergent validity. The KOOS demonstrated convergence with sport function and pain and divergent validity with mental health. This makes sense because the KOOS does not address any aspects of mental health, so you wouldn't expect it to be convergent in that aspect. The KOOS has good reliability with high test-retest reliability, and in terms of responsiveness, effect sizes are large and the MDC is established on a range from 13.4 to 21.1 for the different domains. Each domain has a different MDC because they're measuring different things. One disadvantage of this measurement tool is that the MCID is not calculated. The KOOS is feasible and easy to administer in the clinic. It takes 15 minutes in total to administer, that is 10 minutes to complete and 5 minutes to score. It can be completed in the waiting room or mailed in, and it's available in many different languages and for free online.
The WOMAC is designed to assess pain, joint stiffness, physical, social, and emotional function of a person with osteoarthritis. The goal is to determine the overall level of disability. It was designed for hip and knee, and it does not include knee-related quality of life or sports recreation domains. So this was based on a study that was performed that patients were given the WOMAC and the KOOS, and they were asked different things about both tests, and 91% of the patients reported that it was very, very important / extremely important for the WOMAC to have quality of life and sports recreation domains on it, which it did not have. Some other weaknesses of the WOMAC is that you do need permission to use it and pay for a licensure, which might be a downfall for some clinicians, and it also might be too easy for physically active patients.
The KOOS was developed as an instrument to assess a patient's opinion about their knee pain and any associated problems. It's actually been shown to have better validity but similar reliability when compared to the WOMAC, and it's more advantageous for young populations and populations with a high expectation for physical activity. In a 2014 study, it was actually shown that the WOMAC and KOOS, when they were compared to the degree of cartilage loss that were found in patients with OA, the KOOS actually correlated with the amount of cartilage that was lost. The WOMAC, on the other hand, cannot be used to predict the amount of cartilage loss. Having the KOOS as a correlation to cartilage loss is beneficial because it can be used as a predictor of OA severity. It should, however, be noted that this correlation was found to be somewhat weak, and authors thought that further research would increase this finding. For the take-home message, the WOMAC and KOOS are both reliable, valid, and responsive tools. WOMAC is more appropriate for older or lower functioning populations, while the KOOS is more appropriate for younger or higher functioning populations.